So we started to discuss PSMA, and we are going to make an overview of what can be the impact of this imaging in our daily practice. And unfortunately, I think I will raise more questions that I will answer to questions, but we will see. So again, in new imaging on PET scan, there is a lot of improvements. There is probably in the future new targets, new possibility to detect the cells. And I want first to start with this very simple slide showing that with these different methods, we are not looking at exactly the same thing. If you consider bone scan, you know that it's a biphosphonate linked with technetium, and this imaging is linked with the reaction of osteoblastic due to the tumor cells. When we are looking at PET choline, we know that it's a metabolic tracer and it's associated with the cell's membrane regeneration. And if you look at PET PSMA, PSMA is an antigen on the membrane of the prostate cells. So when you use this imaging, you are looking at the expression of PET PSMA on membrane cells. So clearly, we are not really looking at the same thing. Sometimes we are looking for metabolic tracer. Sometimes we are just looking at the presence of this antigen on the membrane cell. And we'll see that the impact on our diagnosis, on our prognosis, can be a little bit different. So we'll look at the impact of PET PSMA in our daily practice for diagnosis or at diagnosis, for recurrence, for metastatic status, and what are the perspectives. First, at diagnosis. So there is a study looking at PET PSMA with or without MRIs to have a better detection of prostate cancer. And they conclude that when you use a combination, you have a better detection of prostate cancer. And if you look at the negative prognostic value, you see that if you use MRI only, you have a 70% of negative prognostic value. If you use PET PSMA, you have 80%. And if you use a combined PSMA and MRI, you raise until 91%. You increase the sensitivity, but you decrease the specificity. Second point that is very important, and I'm sure that Philippe Camparo will listen to this study. It's a small study of 25 patients, and they look at positive MRI and positive PET PSMA, and they look at the issue that is, does the patient have cancer or no cancer? That means, can we skip prostate biopsy and have a diagnosis of prostate cancer just based on imaging? And surprisingly, if you consider the positive PET PSMA and the PIRATS 4 or 5, you have 100% of the patients who were detected only based on the imaging and on biopsies. We'll see in the future if it's going to be a standard, and then we'll have to find a job for Philippe Camparo. Again? Absolutely. Yep, absolutely. That's right. Second step, it's to use PET PSMA instead of conventional imaging. You know very well the study. We know that when we use PET PSMA, we are doing a better job compared to conventional imaging. We increase the area under the curve by 25%. So that means we increase sensitivity and we increase specificity. We increase the detection of lymph node metastasis by 20%. We increase the detection of metastasis by 15%. We have also this Australian prospective randomized trial looking at PET PSMA versus conventional imaging before surgery. And again, we know that we detect more metastases. And that means that in the daily practice, we are going to change in treatment strategy with PET PSMA in 28% of the case versus 15% of the case when you use only conventional imaging. What is the impact on survival? It's again a question mark. We don't have the answer yet. In terms of cost, in this article, they look at the cost for the conventional imaging versus PET PSMA, and the difference was not very significant, and it was not very, it's just a question of $200 between the two strategies. So clearly it's not, it's cost effective to go for PET PSMA. So if we look at the use of the PET PSMA compared to conventional imaging, do we need, if we have M1 on PET PSMA, but M0 on conventional imaging, do we need to go for a new hormonal therapy? Probably yes, because we know the earlier is the best and it's better for the patient. We saw that when we use new hormonal therapy for patients with castration resistance, we found an impact on overall survival. And of course, when we use this strategy of treatment for metastatic hormone-sensitive prostate cancer patients, we see also an improvement in terms of overall survival. So if we detect the metastatic earlier, we'll have to treat them, and I'm sure that will have an impact. But for the moment, we don't have prospective hormonal trial looking at that. Do we have to go for radiation therapy in this lesion? Again, we don't have for the moment the answer. There is prospective hormonal trial looking at this issue, especially in France, the Presto trial. Do we have to miss the local treatment because we found on PET PSMA 1, 2, or more metastases? We don't know. Perhaps we are going to undertreat some patients, and again, the impact on overall survival is unknown. Let's move to, again, at diagnosis. Can we do and can we avoid lymph node metastasis because the PET PSMA is negative? The answer is no. We have to continue to do a lymph node dissection despite the fact that we have a negative PET PSMA, and this is well reported in this study. So let's look at PET PSMA for recurrence after local treatment. Again, we know very well this study. We know that, of course, it's better when you consider PSMA compared to PET choline. And you see that especially for patients who have a low PSA after local treatment, less than 0.5, you increase the sensitivity to 12% for the choline to 50% with the PET PSMA, and the difference was statistically significant. So clearly, PET PSMA, it's working better than choline, especially with patients with low PSA. And you see, you can start to use PET PSMA with patients with a PSA less than 0.5 nanogram per milliliter. Okay. Is this going to change the strategy? The answer again is yes. In 2/3 of the case, we are going to change the strategy because we use PET PSMA compared to the other kind of imaging, conventional or choline. Is there an improvement in terms of survival? Not for PET PSMA, but for fluocyclovine, there is. It seems to have an impact in terms of survival when the patients were treated based on the result of this imaging and not on conventional imaging, and we'll see in the future if we have, again, an impact. Clearly, we changed the treatment strategy, and this was reported for the use of PET PSMA for radiation therapy for prostate cancer recurrence after surgery. In these studies, they show that they change the dose, they change the volume, they change the location of the treatment. And so clearly, they change the strategy, but in terms of prognostic, for the moment, we have nothing. So this is, again, a comparison for a French study looking at patients who have a PET choline negative and goes for a PET PSMA. They found again that we have a detection rate higher. They detect 80% of positive spot. And the impact of the PET treatment was very high because 76% of the patient changed the treatment that was planned before the PET PSMA. So this is what it discussed concerning the excellent lymph node dissection. We know that we can miss some positive lymph node despite the fact that we have a PET PSMA negative. So clearly for the moment, we don't have a recommendation for that. And we don't have to exclude excellent lymph node dissection because we have a negative PET PSMA. So PET PSMA for the treatment of recurrence in the three big study, the PopStar, the STORMS, and the COMET, we know that if we use this PET PSMA, we are going to impact the PSA of the patient with a follow-up. So I mean, probably we treat better the patients. We can delay the systematic treatment of 1 year, especially in the STORM study. But again, in terms of survival, it's a question mark. So with this PET PSMA, we create new stage. So there is a stage migration and there is a strategy migration. If you look at high-risk prostate cancer with M0 conventional that become M1 on the PET PSMA, it's 20% of the patients that will have this situation. Again, a lot of question mark. Do we have to go for local treatment, despite the fact that we have metastasis on PET PSMA? Do we have to need to add new hormonal androgen therapy? Do we have to use a salvage therapy? What is the duration of new hormonal therapy? Again, it's a lot of question mark. For patients with very high-risk prostate cancer with conventional M0 status that become M1 on the PET PSMA, it's 80% of the patients, so it's pretty high. But again, a lot of questions concerning the treatment. Oligomet on conventional imaging that become poly M1 on PET PSMA. We don't have the proportion of patients, but probably is high. And again, no recommendation concerning the treatment. And for the M0 CRPC, again, if you use PET PSMA, you are going to find 50% of the patients who have who have metastases. And again, what kind of treatment we have to offer, it's a big question mark. So what is the future? Probably, again, we are going to improve the sensitivity and specificity of the detection of PSMA with the CT scan. We are going to have a new generation of this kind of imaging, but probably, again, we'll have a new recommendation in the future. Certainly for PET PSMA, the future is the link with the lutetium that will kill directly the cells. I mentioned this study this morning, and clearly we are looking for the endpoint and the end of the study to have answer concerning the use of lutetium in high-risk prostate cancer patient who had a surgery. So conclusion, what is the impact of PET PSMA in 2023? For diagnosis, it's improved the detection. It's not going to change the strategy, and the impact on oncological outcome is no. At the diagnosis, we improve the detection, we improve the strategy, but for the moment, we have no impact on oncological outcome. If we use PET PSMA for recurrence, it's improved detection, it changes strategy, and it's probably going to change the oncological outcome. For MET, you improve the detection, you improve the strategy, but in terms of outcome, it's again a question mark. Thank you very much for your attention. And sorry because I was not able to give you answer clearly for your daily practice with this PET PSMA.